includes placement of peritoneal dialysis catheters and renal ultrasound. For dialysis patients, dialysis access is their lifeline. And the field of interventional nephrology focuses very much on the maintenance and repair of both vascular and peritoneal dialysis accesses. For those of you who aren't familiar with the field of interventional nephrology, I think this will be an enlightening lecture for you. And I would invite anybody who has an interest, particularly in the residents, to stop by sometime at our suite on the 6th floor of the HCOC and observe the types of fascinating procedures that are done there. So with that, I'll ask Dr. Alsauskas to take the stage.
Thank you very much. All right, so I would like to give today just sort of a big picture, an overview of the types of vascular access, specifically arteriovenous access that we see in nephrology and interventional nephrology and common problems that we encounter. So the goals are to describe the normal function and malfunction of arteriovenous access, also discuss a little bit the issues related to pre-ESRD planning and preservation of veins for future vascular access, and I'll show a few new things that have come along in the last few years in the field of vascular access. So this is just going to be sort of a bird's eye view, no disclosures. So hemodialysis is one of the modalities of renal replacement therapy in people with end-stage renal disease, the other two being peritoneal dialysis and kidney transplantation. It provides solute clearance, removal of urea, potassium, correction of acid-base disorders, and ultrafiltration volume removal. So in order to do hemodialysis, reliable vascular access is essential. And the purpose, obviously, is to remove the blood from the body, clean it, and return it to the body. And vascular access is lifeline for hemodialysis patients. This term gets used quite a bit, and actually, it is most striking when you see a patient that's running out of vascular access and there's no option for vascular access. So options for vascular access are AV fistula, which is the preferred type of access, AV graft, which 99% we see the Gore-Tex or expanded PTFE grafts. There's self-sealing grafts that we don't see as much, but that can be used, and they allow for early cannulation of access after placement. And there's the hero grafts, which are used at the sort of the end life of vascular access options. I'll show that towards the end. And then hemodialysis catheter can be either tunneled cuffed catheter, which can, patients can be discharged from the hospital and they can use this for a while, hopefully while their more permanent access is maturing. And then in the hospital setting or in the acute setting, sometimes we see non-tunneled, non-cuffed catheters. So just a brief diagram of hemodialysis circuit. You have the arterial needle and arterial line. This is a fistula graft. There's arterial pressure monitor. There's a pump that pumps the blood through the circuit. There's the dialyzer where where all the solute and ion exchange takes place and the fluid is removed. And it goes back to the venous line and the blood is returned through the fistula or graft. So we don't just do dialysis. We have to accomplish a certain dose of dialysis. So in the classic nephrology trials, there's a hemo study which shows that if we target a lower dose versus a higher dose, patients with a lower dose actually have a poor long-term outcomes, poor survival. So we target K2 over V more than 1.4. What is K2 over V? That is basically clearance times time divided by volume of distribution of urea. So, if you have a large person, for example, if you have a large denominator, you have to administer more dialysis to accomplish this ratio. So you have to either increase the time or increase the efficiency, the clearance. And, the typical time that we use is 3.5 to 4 hours, blood flow rate of 450 to 500, dialysate flow rate of 600 or more. And what's essential is good access because to achieve these blood flow rates, you have to have sufficient blood flow through the access And it has to be patent from, from the inflow all the way to the heart. If there's any stenosis, then it's possible that what can happen is what's called recirculation, where you're just basically cleaning the arm and not providing systemic clearance. So this is key. Whenever I have a bad day, I always think back to the 1940s, what the patients had to experience when dialysis was first started. So there was no vascular access and there was no chronic dialysis. It was done acutely for acute renal failure, for example, glomerulonephritis. And for every single treatment, patients had to have basically fresh, cut down of artery and vein that would be cannulated, and dialysis would be done. And patients would either recover renal function or die, And often they would run out of vascular access or develop complications related to, these cannulations. So back in the 1960s, Dr. Scribner at the University of Washington invented this device called Scribner Shunt, where he would connect a PTFE tube to the artery, and he would run in a loop configuration, return it to the vein. The reason is to maintain blood flow, and to prevent it from clotting. As you can imagine, this would get infected, this would get clotted quite a bit. But this was a good step forward. And then actually in 1966, Dr. Brachial and Semino, Dr. Semino, I understand, was a phlebotomist at the Bellevue Hospital in New York, and he would see these war veterans that would come with war injuries, and they would have traumatic AV fistulas that were, of relatively little consequence. They didn't bother the patient, but he noticed that they're a good way to stick the patient for blood draws. So when he became a nephrologist at the Bronx VA, they started creating these surgically. And, this was 1966, but actually to this day, this is the gold standard, If I see a patient with a good AV fistula, radiocephalic fistula, at least from the vascular access point of view, patient is in good shape, So very briefly, overview of anatomy. For our purposes, you have to know the arm has the cephalic vein on the outside, the basilic vein runs on the inside. There's the brachial artery that branches into radial artery laterally, ulnar artery medially. And then central veins, you have the axillary vein that comes in and becomes subclavian vein. It is joined by the IJ. It becomes brachiocephalic vein or innominate vein. And the brachiocephalic veins join to form SVC. As you can see on the right side, the brachiocephalic vein runs sort of straight down. And on the left side, it turns and makes a 45-degree angle. So whenever you put the tunneled catheter, for example, you always have to use a longer catheter on the left, and because of all the turns, there's more catheter dysfunction, so the preferred site is the right IJ. Okay, this is a diagram with all possible axes. Some of them I've never seen, for example, renal artery to renal vein, but just to briefly overview what we commonly do see. For fistula, the radial cephalic fistula in the forearm, and this is typically the first choice, to create a radiocephalic fistula in the non-dominant arm. The reason being is, if the fistula becomes dysfunctional down the line, you can go up, and, while the fistula is working, there's secondary fistulas developing in the upper arm, so the veins are getting large flow and they're getting bigger, so that if the radiocephalic fistula fails, surgeon can go back to the upper arm and fairly quickly create a fistula with a vein that's already big and matured. Brachial artery to cephalic vein in the upper arm, lateral aspect brachial artery to basilic vein on the medial aspect. The issue with this is that, the basilic vein runs kind of underneath the arm and is kind of deep, so even if the vein is big, you can't cannulate it. There's a second stage called transposition where there's a longitudinal scar and the surgeon moves the vein up and laterally. And, sometimes we see femoral artery to saphenous vein fistulas in the thigh that can be either straight or in a loop configuration. Those are pretty good options sometimes. AV graft can be utilized. It can be in the forearm, radial artery to cephalic or basilic. It can be a straight graft in the forearm. It can be a looped graft in the forearm. Once you go to the upper arm, you have brachial artery to axillary vein or brachial artery to basilic vein grafts. You can have axillary to axillary loop grafts. And then you can have a thigh loop graft, femoral artery to femoral vein or femoral artery to saphenous vein. Occasionally you will see things like, necklace grafts that run across the front of the chest. I've never seen an IJ graft, but I guess they are described. Tunneled catheter, the 99%, probably it's the internal jugular. Tunneled catheter, it's commonly erroneously called the subclavian vein catheter. It's not subclavian because, you can feel it with your fingertips. It runs over the clavicle and it exits in the front of the chest. We try to avoid subclavian vein catheters because they cause a lot of central vein stenosis because of the puncture of subclavian vein and the anatomy. I will show you some other translumbar and transhepatic catheters that are sometimes used. That's the end of life options, basically. And femoral vein catheter is sometimes used, but we try to stay away from them for reasons of, high infection rate. So some examples: AV fistula, brachial cephalic fistula on the outside of the arm, brachial to basilic fistula. It makes a loop, it goes in the armpit, and there's a long scar. And radial cephalic fistula in the forearm. Okay, graft can be straight or looped. It's an expanded PTFE or vortex material. So this is an example. It's arterial anastomosis and it's looped back to the vein. How do you determine which is the arterial side and which is the venous side? You can briefly occlude the graft in the middle, especially if it's a loop configuration. It's hard to know sometimes. And then, the side that's pulsatile, that's the arterial side. Going back to the grafts versus fistulas, fistula is preferred because the lifespan of a fistula is longer. There's less stenosis, less infection, less interventions. Problem with the fistula is, you have to have good vein and good artery to start with. So if you put a fistula using a small vein, sometimes you wait for months and months and it never gets big enough to the size that you need to use for dialysis. And in the meantime, patient is with a catheter. So what's the problem? What do we do with these fistulas and grafts in interventional nephrology? So the most common lesion is stenosis anywhere along the length of the axis, and it's due to neo-intimal hyperplasia. Where do we see the stenosis? Like I said, we can see it anywhere, starting from the artery, at the arterial anastomosis, the fistula itself, peripheral veins, outflow veins, and then central veins. So depending on the location of the axis, for example, forearm fistulas, there's a lot of stenosis at the arterial anastomosis or juxta-anastomotic segment. There's some stenosis in the body of the fistula itself. In the upper arm fistulas, there's quite a bit of stenosis depending on whether it's cephalic or basilic. In cephalic veins, there's a structure called cephalic arch. It's like a loop that where the vein turns in the shoulder area. And in the basilic vein, when the vein is transposed, there's an area called swing segment where the vein is kind of moved laterally and stretched a little bit. So there's a lot of stenosis in cephalic arch in the swing segment of basilic vein, but there can be stenosis anywhere else as well. Okay. So with grafts, majority of stenosis is at the venous anastomosis. That's where the graft meets the vein, where prosthetic material meets the vein. But there can be inflow stenosis and outflow central vein stenosis as well. So this is a study that, it's a meta-analysis actually, that looked at multiple studies, and they wanted to, this slide basically shows primary patency, which is the time from access placement to the first intervention that's required to maintain patency. So as you can see, by 6 months, probably 40% of grafts require intervention, and maybe 25% of fistulas require intervention. Cumulative patency, that's the overall life of an access until it either clots and cannot be declotted, or until it requires surgery to maintain patency. So, at 2 years, probably 40% of the grafts are gone. So I tell my patients, half-life of a graft is roughly 2 years. So after 2 years, almost half of them are gone. Much better with the autologous vein. Okay, and this process of neo-intimal hyperplasia has been well characterized. You have thickening of the intimal layer in the vein. It's thought to be due to these myofibroblasts that migrate into the intima, and this is showed by alpha smooth muscle actin stain. There's neovascularization in the neo-intima von Willebrand factor staining. If there's a graft material, sometimes they see these giant cells, macrophage giant cell reaction, presumably because of the graft material. And there's all kinds of pro-inflammatory, pro-proliferative cytokines expressed in the neointima. There is migration of cells from adventitia fibroblasts that become myofibroblasts and proliferate in the intima. There's another thing, so when the vein matures, there's some neointimal hyperplasia, but there's also remodeling of the vein where the vein dilates, the media of the vein thickens, and there's some patients have a problem with adventitial remodeling, so the vein is unable to dilate, and if there's an inability to dilate in some area or another, that's a potential site for stenosis. So this other diagram here shows that the lumen is exactly the same. There's more stenosis here, but as long as the vein can dilate, potentially there's going to be no obstruction. If the vein cannot dilate, then smaller degree of proliferation will cause a significant stenosis. There's also some evidence that even in the veins of end-stage renal patients prior to placement of an access, there's some process going on. There's a proliferation, hyperplasia, neointimal hyperplasia, and that was well characterized in a hemodialysis fistula maturation study where they prospectively followed about 400 patients and they took samples of the vein at the time of surgery. So what are the causes of neointimal hyperplasia? So first of all, abnormal hemodynamics. Veins are not physiologically designed for high pressure, high flow coming from the artery. There's turbulent flow at the sites of turns and so on, and the wall shear stress. There can be foreign body reaction, as I showed. There can be recurrent injury from dialysis needles in the access. There's surgical stress at the time of creation of access. Perhaps injury from angioplasty balloons. So, we try to not do angioplasty unless absolutely necessary for clinical indications, even though there might be stenosis. And then perhaps uremic milieu, the cytokines and pro-inflammatory state in the end-stage renal patient. So different things have been tried to try to treat this neointimal hyperplasia, such as one of the most recent studies is a paclitaxel-coated balloon, which would deliver a dose of anti-proliferative drug to an area of stenosis, but actually it was a negative study, unfortunately. Some other things have been tried, such as sirolimus-eluting wraps that are placed at the time of the surgery, adventitial wraps, and things like brachytherapy. Nothing has really shown to be effective so far. Okay, so let me describe some clinical cases of arteriovenous access dysfunction and show how they manifest and what we do to treat them. So there's three common scenarios. There can be inflow stenosis at the arterial anastomosis or somewhere in the artery. There can be outflow stenosis in the peripheral outflow veins, and there can be central vein stenosis. So it's hard to describe physical exam, on the screen, but I'll just try to briefly describe what we feel, what we see, By the way, physical exam of vascular access is difficult because when we see patients on dialysis, they have their fistulas or grafts cannulated, they have dressing, their arm is kind of immobilized, but we do have a vascular nurse who goes around once a month examining everybody's access that's not cannulated, and she can pick up most of those problems. So normally fistula is soft and easily compressible. You can feel a continuous kind of systolic-diastolic thrill and, auscultate a bruit. The fistula collapses nicely with elevation, with gravity. I'll show you in the next slide. And there is what's called the good arterial augmentation. So if you occlude the fistula briefly with a finger proximally and you feel the distal part of the fistula, it's going to become strong and bounding. That means there's good inflow coming from the artery. So in the case of outflow stenosis, the fistula is going to become hyperpulsatile, sort of like the way you would feel it if you did arterial augmentation test. What you might feel is only a systolic rather than continuous systolic-diastolic thrill, and you're going to hear a systolic high-pitched bruit, especially at the area of stenosis. When you raise the arm, it's not going to collapse because there's a stenosis and, the vein cannot kind of drain with gravity. Inflow stenosis, the fistula itself will be kind of weak and soft. There's not enough blood coming from the artery. There might be a weak thrill and bruit, and there's poor arterial augmentation because there's not enough blood coming from the artery. So this is the collapse of the fistula with gravity. Arm elevation test. Nice radial cephalic fistula collapses nicely. Here's another example of nice fistula that collapses with the elevation of the arm. Okay, so physical exam aside, there's clinical problems that patients experience if there's a stenosis. So for example, if it's a normal fistula, as I showed you in the slide with the dialysis circuit diagram, we monitor dynamic pressures, so we monitor pressures in the arterial line and in the venous line. And normally these pressures are within the acceptable range limits. The clearance is good, presuming that the patient stays on dialysis, long enough. Cannulation is easy. The nurse doesn't have to look hard for the vein. And when they remove the needles at the end of dialysis, there's not a prolonged bleeding. Usually hemostasis is obtained within 5 to 10 minutes just by holding, light manual pressure. If there's outflow stenosis, there's going to be high venous pressures. Clearance will be low because the blood will be recirculating within the segment that's cannulated. And there's going to be prolonged bleeding. Patients have to hold pressure for 15, 20 minutes, half an hour sometimes. Inflow stenosis, there's going to be abnormal arterial line pressures. They're normally negative because there's kind of suction effect. And if there's inflow stenosis, if there's not enough blood coming in, the suction can kind of collapse the fistula and the needle can suck up against the wall of the vein and you will have arterial line pressure alarms. Low clearance, just like with outflow stenosis, there's not enough blood going through the fistula. And nurses have a hard time cannulating because the fistula is very weak and, they can't stick it. So there's other ways to monitor the access. For example, one method that we use is access flow measurement. So just to briefly describe it, this is the fistula, blood coming in from the artery. The arterial and venous needles are reversed. And there's a bolus of saline that's given through this distal needle, and it mixes with the incoming blood, and it's picked up by the ultrasound sensor on the arterial line. So if the flow through the access is very rapid, this saline will be diluted, and the signal through the arterial line will be kind of low. And computer, calculates what's the estimated flow per minute through that access. This is pretty high flow, for example. There's a way to measure recirculation. In other words, is it kind of a closed circuit? Are you just cleaning the arm rather than providing systemic clearance? So here the arterial and venous lines are in the usual position, and the bolus is given through the venous needle, and normally it should go upstream. But if there's an upstream stenosis, for example, sometimes there's a reflux of blood, and that's picked up by the arterial needle. Normally there's no recirculation, but you can trend that over time, and if it's rising, that's an indication for angiogram. This can happen occasionally due to improper cannulation. For example, if the needles are too close together or if the tips of the needle are facing each other, recirculation. So this is a good access with no recirculation. This is an access with high recirculation and low access flows. Normally flows that we see in the grafts, they have to be at least 600 milliliters per minute through the access itself. In fistulas, usually it's larger even than that. So we can measure the absolute blood flow, and we can measure relative reduction. If there's a 25% reduction from 1 month to the next, that's pretty sensitive for some sort of stenosis in the access. We can detect high flow accesses too. That can be problematic, and lead to high output cardiac failure sometimes. So there's studies that show, for example, that decreasing flow intragraft, indicates that there's a higher likelihood of thrombosis in these accesses. So there's studies that show, prospective studies that show, for example, in this study, there were 3 phases. One was no monitoring. The other one was, I believe it was dynamic pressure monitoring, and this was access flow monitoring. So if you monitor access flow, you're going to decrease the rate of thrombosis in grafts, which is black, and light gray is fistulas. Monitoring of access flows decreases hospitalizations, decreases mistreatments, and decreases the need for catheter replacements. But of course, it increases the number of angiograms, and interventions that are done. So some more recent studies show that it increases, the monitored group has a lower incidence of thrombosis. It's a little bit controversial. It's not fully evident that this prolongs the overall access lifespan, and the economic analysis is not entirely clear whether or not it's economically feasible to do all these extra interventions just for this indication. So summary, physical exam, these are the parameters that we monitor. Physical exam, other problems, on dialysis, such as venous pressure alarms, K2/V, and other things such as hyperkalemia, intra-access flow monitoring, recirculation monitoring, and pressure monitoring. And access surveillance will lead to interventions that will hopefully, lead to fewer of those, adverse outcomes in dialysis patients. So some images to show what we see and what we can do about these things. So this is, for example, I believe it's brachial cephalic fistula, brachial artery, and you see a tight stenosis at the inflow. After angioplasty, you can see a nice resolution of stenosis. We aim for diameter of the lesion that's roughly equivalent to the diameter of the feeding artery. This is another one, periarterial anastomotic stenosis, with good result after angioplasty. So this is a brachial basilic fistula with a stenosis, probably 70% stenosis at the swing segment. It doesn't look like there's a turn, but that's because of the projection of the X-ray. That's where the vein makes the turn. And you can see surgical clips near that area. So we can put a balloon. This is a 12 millimeter balloon. You see a nice waist at the area where the stenosis is, and as you inflate the balloon, you actually feel the balloon sort of give and pop. It's kind of like a controlled rupture of the lesion with a good result. Okay, this is a brachial artery to cephalic vein, AV fistula. You can see that the cephalic vein sort of disappears in the cephalic arch region. You can see a reflux of contrast. Normally, the flow of contrast is, forward, upstream. Here, because of high pressures intra-access and it's actually occlusion, there's a reflux into the artery. The wire can be passed even through complete occlusion, and balloon can be placed. There's a tight area of stenosis. Very faint contrast here, but you can see that there's restoration of flow. Okay. Sometimes these stenoses are sort of resistant, so the indication for angioplasty is 50% stenosis in the context of arteriovenous access. The indications for stent graft placement. Stent grafts, there's different brands, different designs. We use a nitinol stent with PTFE lining. The indications would be rapid recurrence of a lesion if they have to come back less than 3 months. If it's elastic stenosis, so if you can inflate the balloon, but once you let it down, the stenosis comes back immediately. Or sometimes we see rupture of the vein after angioplasty with extravasation of contrast, so you can cover that area with a stent graft. Stent grafts provide, longer, short-term patency, but over time, there's problems with stents. There can be in-stent stenosis. There can be end-stent stenosis called candy wrapper restenosis that can be angioplastied. The problem with these in-stent stenoses is, it's sometimes harder to break them because you can't really rupture this. You can't really stretch the stent all that much. So it's a temporary solution, but not necessarily a permanent fix. Okay, central vein stenosis, that's the third scenario. And here, for example, we have a patient that comes in with arm swelling. Usually, if there's swelling of the arm or leg, that's a sign of central vein stenosis rather than peripheral vein stenosis. There's 3 venous systems in the arm, for example. There's a cephalic, basilic, and there's a deep brachial veins. So if there's stenosis of 1 or even 2, usually the third one is sufficient to maintain, flow, and there's no swelling. This, for example, is a tight stenosis in the subclavian vein. You can see cephalic arch, subclavian vein, and you can see extensive collaterals developing from the peripheral veins. Okay, this is a diagram that summarizes the findings in central vein stenosis. So the fistula can be pulsatile, but sometimes not because of the collaterals. The blood can be drained. Usually you can see the reason why they have a central vein stenosis. So you might see scars from previous catheter placements. There might be a pacemaker on that side. You will have swelling of the arm. Swelling is a problem sometimes, not just discomfort, but also the fistula can become sort of deeper if the swelling is severe and is harder to cannulate. It might not be usable. And you will see extensive collateral network usually. So this is a sort of Caput-Meduse type of picture with IVC occlusion. This is very faint. You can't really see it, but there's a venous collateral network. These are scars from previous catheters. Arm is swollen pre-angioplasty, and the swelling gets better after angioplasty. And, in this case, this is a right brachiocephalic vein, tight stenosis, probably 90%. And the probable likely reason is the pacemaker wires that come in from the other side. This is another example of brachiocephalic vein stenosis with collaterals. Okay, this is another example. Extensive collaterals on the arm, collateral veins. These can be seen pretty well. And there's an occlusion of the subclavian vein with some collaterals that is fixed by angioplasty. The risk factors for central vein stenosis are obviously central venous catheters, and some things that increase the risk would be the number of catheters, duration that the catheter stays in place, location of the catheter, subclavian much greater than IJ. We never use subclavian unless it's the last resort. PICC lines cause not only peripheral vein damage where they're inserted, but also central vein stenosis as well. Cardiac devices such as AICDs and pacemakers. So these days it's possible to place an epicardial lead for a defibrillator, for example, so we request that whenever possible. Ectatic aortic arch can compress the left brachiocephalic vein sometimes, and that can be a problem. Sometimes there's a stenosis at the costoclavicular junction between clavicle and the first rib where the subclavian vein is compressed. This is not going to be fixed, unfortunately, by angioplasty or even putting in a stent. The stent will be crushed from the outside. So this can be surgically corrected, but it's a pretty traumatic surgery. I haven't actually seen anyone undergo this decompression. Okay, so this is an example of a patient that has this huge tortuous fistula in the upper arm. That's called the megafistula. And the issues with this is cosmetic, obviously. Sometimes the skin can become kind of thin and these things can rupture, and then the high flow can be associated with high output heart failure. This patient underwent ligation of the fistula, and he had another fistula placed on the contralateral side that also became a megafistula, unfortunately. So it's not entirely clear why these develop. Sometimes it's a matter of, the arterial anastomosis is too large, but there might be something intrinsic about the properties of the vein wall that predispose the patient to this massive dilation of the vein. Patients can develop pain in their hand. If the hand is cold and blue and there's lack of radial artery pulse, that's very concerning for ischemia. That can be due to some lesion in the artery, or it could be a steal through the axis. So the axis sort of diverts the arterial flow to the distal extremity. You have to be cautious about it. If there's severe pain, and lack of pulse, that can lead to loss of fingers, gangrene, things like that. Treatment would be ligation of access, or often surgeons can do some sort of bypass to correct that. So the classic surgery that we see is called drill, distal revascularization with interval ligation, where the artery is ligated. This is the arterial anastomosis. This is where the artery is connected to the vein. The artery is ligated, and there's a graft that connects the proximal artery to the distal artery, and that prevents retrograde flow into the fistula from the artery. Fistulas and grafts can develop aneurysms. Usually aneurysms are in fistulas. That's the sort of focal dilation of the vein, usually at the site of repeated cannulation. Grafts can develop pseudoaneurysms. And I'll show you here. So graft is a prosthetic material. When you punch out a hole with dialysis needle, it doesn't heal. That's the problem with the graft. So if there's repeated cannulation at the same site, this defect can become fairly large, and then that area sort of expands, and the blood is only contained by subcutaneous tissues. So, we always ask nurses to rotate cannulation site. It's called rope ladder technique. You utilize the whole length of the access, not just hit two areas. That's a problem because, sometimes when you hit the same area, it becomes dilated and it's easier to hit that area again. So the nurses kind of keep doing the same thing and there's two big bulges on the access. It's called one-site-itis. So what are the things that are concerning? Skin ulceration, any kind of bleeding would be, obviously concerning. The skin becomes thin and depigmented sometimes, and if the skin cannot be wrinkled, if it's tight, if the access is pulsatile, the skin is thin and tight, that's a concern. You refer them to the surgeon ASAP. Here, for example, there's some thinning, but it can nicely be wrinkled. That's probably okay. It's a fistula. It's an aneurysm. Infection, we see that more with grafts than fistulas. Not that often, but occasionally we see. This looks like it's a fresh surgery that's already infected with some abscess, so it will have to be explanted. Sometimes accesses clot. So how do you know access is clotted? If you put your fingers on the graft or fistula, there's no brewery, no thrill, no pulse. It's a dead access. Thrombosed fistula is an emergency, so we try to declot it the same day or the next day. If you wait 3-4 days, for some reason in the vein, the clot becomes organized very quickly, and then it's harder to declot it. Grafts can wait up to a week. But if a fistula gets clotted on Friday, for example, we try to declot it the same day. So the classic triad, Virchow's triad for thrombosis would be blood stasis, endothelial injury, and hypercoagulability. So actually, in dialysis access, stasis is the most common reason for thrombosis due to stenosis somewhere along the length of the access. Less commonly, if there's inadvertent occlusion, for example, patient sleeps on the arm, or somebody puts a blood pressure cuff on that arm, Sometimes hypotension can cause clotting. Period of decreased blood flow through the access will cause clotting. So sometimes people ask me, do you put them on Coumadin or anticoagulants? Actually, most of the time, probably 95% no, because rarely we do hypercoagulable workup. Usually if there's recurrent thrombosis and there's no discrete stenosis that we can identify, or if there's very early thrombosis after surgery, for example. So we have seen patients with antiphospholipid antibodies, factor V Leiden, and so on. Okay, we can do percutaneous thrombectomy. It's an outpatient procedure, basically. To briefly describe it, as this is a loop graft. We cannulate it with a sheath towards the vein, and we use a special catheter called angiojet catheter that injects fluid into the graft under high pressure and then kind of aspirates it. So the clot is broken up mechanically and kind of sucked out through the catheter. Next, we correct the stenosis with an angioplasty balloon, usually at the venous anastomosis in the case of a graft. And the last step is we use a Fogarty balloon to pull the plug from the arterial anastomosis, and then the graft is open. Occasionally, they need a stent. They're heparinized during the procedure. That's probably the most involved procedure that we do. It takes probably about an hour, but just conscious sedation, outpatient procedure. Patient goes home or goes to dialysis. There is some data that shows that if the access clots, even though you might be able to declot it successfully and there's 0% residual stenosis, there is some evidence that nonetheless these patients have poorer long-term patency and they require repeat intervention sooner. So thrombosis is a problem. It's not clear exactly whether Earlier angioplasty due to more intensive monitoring and prevention of thrombosis would improve the access survival. That wouldn't be enough to show that, I believe, but thrombosis is bad. If the graft clots 2 or 3 times, that usually means it's end of life for that access. Okay, so a little bit about maturation of AV fistulas. When the surgeon connects the artery to the vein, it undergoes maturation, which is a process where the vein expands. It sort of arterializes the media. There's thickening of the media, and there's dilation of the vein. The fistula can be used successfully, and then neointimal hyperplasia is what causes stenosis and failure ultimately. Sometimes there's failure to mature, where the vein remains small, and the reasons are several, probably a small artery, small vein, and some other factors. So when do we put an AV access in somebody that we anticipate that will need dialysis? If it's KDOQI guidelines, they will be updated soon, but the last version states that we should put fistula at least 6 months prior to anticipated start of dialysis treatments. It's sometimes hard to predict when they will need dialysis, but usually in CKD stage 4, we put in a fistula, and we need time because it's not ready to be used immediately. It takes at least 3 months, sometimes more. Sometimes they need interventions to facilitate maturation. AV graft is a different story because it's a preformed, prosthetic tube. So all it needs to do is the tissues need to heal around the graft so you can cannulate it without causing a hematoma. So usually 3 weeks should be sufficient, prior to anticipated start of dialysis. Despite all these efforts, unfortunately, this is national data from last year. 80% of patients start dialysis with a catheter. So that's a pretty terrible number. And the reasons are multiple, late referral to the surgeon, failure to mature, patient's reluctance to undergo surgery, and so on. But by 2 years, it's probably about 70%, almost 70% that have a functioning AV fistula. This is just access in use. If you look at the overall outcomes, it's a little bit different picture. There's a lot of mortality by 2 years. Relatively few patients undergo transplantation, and there's a reduction in catheters. There's increase in fistulas, but there's a lot of mortality as well. So this appears to be a brachial basilic fistula. What is a good fistula? When is it ready to use? So we have a rule of 6s. It means it can be cannulated 6 weeks after creation. Blood flow through the access at least 600 milliliters per minute. There's at least 6 centimeters straight cannulation segment for 2 needles to be placed, apart so that it doesn't recirculate. It's superficial, less than 6 millimeters beneath skin surface, and it's at least 6 millimeters in diameter. So some data from the fistula maturation study. This is well characterized. About 400 patients show the increase in the diameter of the veins. The upper arm fistula increases more so than the radial cephalic fistula. The flow increases over time by 6 weeks, and these are the flows that are accomplished by 6 weeks. And upper arm fistulas appear to mature faster, and they're bigger, but we still start with the forearm because we want to preserve veins for future use. In the era of Brescia Semino fistula, in the 60s, there was probably a 10% fistula failure to mature. These days, it's about 20 to 60%, and that has to do largely with the change of population characteristics. Older patients, more vascular disease, hypertension, diabetes, as opposed to young patients with glomerulonephritis back in the 60s. Causes are multiple. It can be arterial stenosis, venous stenosis. It can be either focal stenosis or just diffuse failure of the vein to dilate. Accessory veins, sometimes the vein has a branch that drains the blood to the side, and it doesn't allow the pressure to build up in the main channel, and the vein does not enlarge. Thrombosis for various reasons. Risk factors for failure to mature would be non-Caucasian ethnicity, older age, female gender, diabetes, vascular disease, obesity, hypercoagulable state, and then anatomy. Radial cephalic fistulas are the worst. This is an example of accessory vein. This is a brachial to cephalic fistula in the upper arm, and there's a large vein that goes down. So this main vein does not get enough flow. So this vein can be ligated percutaneously, or it can be coiled with an endovascular coil. Okay, briefly about preservation of veins for vascular access. So whenever we have patients with CKD stage 3 and 4, we're always very nervous to make sure that these veins are preserved for future vascular access. So it's recommended to avoid venipuncture and any kind of IV access, except preferably try to stay with the dorsal veins of the dominant hand. That's where they're not going to have a fistula, hopefully, at least the first time around in the dominant hand. No PICC lines. PICC lines cause central vein stenosis and also peripheral vein thrombosis at least 40% of the time. Obtain vein mapping in CKD stage 4. There's two options for vein mapping. One is ultrasound-based, which shows both the vein and the artery. The classic criteria are the artery has to be at least 2 millimeters in diameter, vein at least 2.5 millimeters without any focal stenosis upstream. Timing of access depends on the rate of progression of renal failure and whether it's going to be fistula or graft. We don't place graft until they're very close to dialysis. And then timely vascular surgery referral. This shows national trends of different types of accesses over the years. So 2003 was when the CMS started this Fistula First initiative, where there was a large push to, try to place as many fistulas, avoid grafts, and definitely avoid catheters. So the grafts and the catheters have, reversed from 2003. But unfortunately, it has plateaued now, and there's some limit to how many patients can have a functioning fistula. The problem is, like I said, if the fistula never matures and you're afraid to put in a graft, they just end up staying with a catheter for a long time. So proper patient selection is important. I want to show a few, this is sort of related to preservation of veins. I want to show a few devices that are used when the patients are running out of access. So this is, for example, a hero graft. It's a hybrid device where there's a peripheral graft that's connected to a catheter. And the reason for this catheter, the catheter goes in the veins, it goes through the central veins into the right atrium. The reason is that there's a central vein stenosis that's refractory to angioplasty or stenting. So the catheter sort of bypasses the central vein stenosis. So this is, for example, occluded left brachiocephalic vein. I don't know if you can see, I think there's a stent in there. They were able to angioplasty it, but it's probably going to recoil very soon, so it's not going to last. But they were able to thread the wire and angioplasty it, and they thread the hero graft, and it's connected peripherally. So it's a viable access. We have a few patients with these that can last, pretty good period of time. This is a transhepatic catheter. I've seen one or two of those. When there's no other place to put a catheter, the liver is cannulated under ultrasound, one of the hepatic veins, and the wire is threaded into the IVC, and the catheter is put through the liver. That's a pretty terrible thing. So there's something called translumbar catheter, where the IVC is directly cannulated under ultrasound guidance, and catheter can be placed in the IVC. And this is a hero graft that connects the subclavian artery, runs on the side, and then becomes translumbar hero graft into the right atrium. So we try to avoid these things. That's the main reason for this whole access monitoring and access preservation. Sometimes patients run out of access completely, and the options are to do peritoneal dialysis. There's also a thing called compassionate kidney transplantation, where unless there's an absolute contraindication, they're bumped up on the list to the top to try to save their life. So to end the talk on a positive note, a few recent developments. There's bioengineered AV grafts. There's different types. I will show one of them where there's a scaffold that's seeded with a tissue culture of smooth muscle cells, and it's grown in a bioreactor in a tissue culture medium under pulsatile conditions. So these cells create connective tissue matrix, and then the graft is decellularized chemically. All the antigens are removed, and this is the end product that's implanted into human, and it gets repopulated with cells. It gets incorporated and repopulated with native, human cells. They show that cumulative patency is pretty comparable to AV fistulas. They hope to use these grafts in the arterial setting, such as peripheral vascular disease or maybe even carotid disease. But AV fistula was sort of a good target to test it out and make sure it works well, and it has excellent outcomes. This shows that it's repopulated with cells, it's endothelialized. There's a couple of different systems to create fistula percutaneously in an outpatient setting. So, for example, I'll show one of them. The vein can be cannulated under, first of all, the arteries and veins are mapped with ultrasound. And in the antecubital fossa, one of the veins is cannulated and the connection is made into the radial artery. And then this special catheter is placed that uses radiofrequency energy to create anastomosis percutaneously. So you can see that the catheter is placed from the vein into the radial artery. And this is this radiofrequency catheter, and you can see immediately a fistula. Sometimes this area requires angioplasty to enlarge it. It's a pretty involved procedure. Sometimes it requires coiling of deep brachial veins upstream and downstream to allow flow through the main channel. But when it works, it's a great thing because this is the artery, and it actually creates a dual fistula. There's a cephalic vein and basilic vein. And, there's no scar. You can see this V-shaped configuration. You can cannulate it with 2 needles, and they show in their clinical trials very good cumulative patency. So that is pretty much it. I just want to mention a few other things that we do other than vascular. We can work on tunneled catheters. We can place a catheter, remove a catheter when it's no longer needed, exchange a dysfunctional catheter. We do vein mapping by venogram. That does not show you the artery, but that's preferred when you suspect there might be central vein stenosis, such as patients with prior PICC lines, tunneled catheters. We can coil an accessory vein. We do kidney biopsies, native and transplant, and we just do, regular non-invasive kidney and bladder ultrasounds, both in the office and in the hospital. So thank you very much. Any questions? Thank you.
Thank you, Jay. So I think that a seasonal routine that I think vascular access is the ideal. So
well, I think they have to have sufficient, they have to have good anatomy, which would be determined by, ultrasound-based vein mapping. We don't have any experience with this, but presumably if the anatomy is good, the outcomes are good. Mm-hmm. No, I think it's a different process from atherosclerotic plaque. But as far as a pre-existing stenosis in the native veins, this fistula maturation study, there was a separate paper where they showed that there's actually a very weak correlation between stenosis in the intact axis in terms of how severe the pre-existing stenosis was. So as long as the vein is sufficient size, that doesn't appear to play much of a role, at least in that study. The native vein, the pre-existing vein stenosis prior to access placement. If somebody has stenosis, most people develop stenosis. If somebody has stenosis, the likelihood that it will recur is high, usually at the same site. I am not aware of any studies that looked at that. I mean, well, you know, most dialysis patients are on active vitamin D or vitamin D analogs, mainly for the treatment of secondary hyperparathyroidism, but I'm not aware of any studies that looked at vascular access in terms of vitamin D. Yeah. Thank you.